Dr. David Mikulis is a full professor and director of Functional Neuroimaging Research Lab in the Joint Department of Medical Imaging in the University Health Network and the University of Toronto. The primary emphasis of his work has been translational research, focusing on application of novel imaging methods into the clinical environment. He established one of the first fMRI labs in Canada in 1993 and is currently involved in developing advanced neurovascular imaging methods, one of the major program arms including quantitative measurement and clinical application of cerebrovascular reactivity metrics, leading to the development of the brain stress test, which is analogous to the cardiac stress test. Translations of these methods has been achieved locally, nationally, and internationally, confirming the importance of these tools in research and clinical settings. And we're very excited to hear about these tools and about your exciting work. And I will leave the floor to Dr. Mikulis.
Okay, well, Miriam, thank you for that kind introduction. I'm honored to be able to present at your grand rounds. I am going to present on the brain stress test. This is something I've been working on for the last 20 years or so. So with that, I'm hoping that you can see my screen. I guess I share at this point. Okay, terrific. Okay, so I have a lot to cover, so I'm just going to jump right in here. So this is the latest and greatest CVR map. We collected it just this week, this past Monday. We're scanning 2 patients, clinical cases a week. This was a 68-year-old man with vascular risk factors, and he had TIAs. You can see that he doesn't have a left internal carotid artery. Do you see my pointer?
Yes, we can.
Oh, you can. All right, great. So he has no left internal carotid artery. He's filling his left MCA across the ACOM. And you can see that he has these blue areas in his brain. And this is where the bold signal becomes negative when we apply a global CO2 stimulus. So this patient has steel physiology. He clearly, based on this study, has hemodynamic compromise caused by his carotid occlusion. He also has a stenosis on the other side, interestingly enough, and it looks pretty intense. But his CVR is terrific. It's very close to normal. And we acquired this data with a Siemens Vita system, 32-channel head coil. This is the TR and TE, and we have 2.5 millimeter isotropic voxels. And you can see we can even measure CVR in the cerebellum. We still miss a little bit of the brainstem, inferior temporal lobes, and inferior frontal lobes because of susceptibility effects. But other than that, we can scan the whole brain. Okay, so with that, I want to begin actually by discussing how I got to where I am and how this brain stress test evolved. I'm just wondering, does anybody know who Alan Cormack, one of my mentors, is? So a lot of the people in this list are kind of mothers and fathers of their areas of expertise. And Alan Cormack was my advisor when I was a physics undergraduate. He invented the CT scanner. He won the Nobel Prize for this. And he was a physicist who built a desktop CT and actually did first reconstruction of images with blocks that he had set up on his desktop. So this was, I think, the reason I'm here speaking to you today is because he influenced my direction, my future direction. Then I went to medical school, got to Mass General, worked with Juan Tavares, who's the father of neuroradiology, and he got me interested in research. While I was there, I met C. Miller Fisher, who was a Canadian neurologist there who's very interested in stroke. And that influenced another direction in my career, which is assessment of the cerebral vasculature. Then I got involved with Bruce Rosen and Ken Kwong. They're the fathers of functional neuroimaging, which I did for a while. And then I met Bill Logan, and I'll talk about him in a little bit. He was a neurologist at Hospital for Sick Children in Toronto. And he had a major influence on my career direction. And I just wanted to mention Gabrielle DeVeber. She's the mother of pediatric stroke, and I happen to be married to her. So if you happen to bump into her, tell her that I consider her to be one of my greatest mentors. So with that, I'm going to begin by talking about Bill Logan. So Bill was at Mass General, and he started using breath hold techniques and bold MRI to match CVR in the human brain. And I had been working for some time on fMRI, and this is what I was doing, mapping networks. And I thought that we could measure brain performance to the degree where fMRI would become diagnostic. So we may see a patient who had basically a normal MRI and make diagnoses such as autism and schizophrenia and movement disorders and that sort of thing. And after doing this for about 10 years, I suddenly realized that we weren't able to make diagnoses with it. And I think to this day, it's still not a useful diagnostic tool. So I decided at that point, with Bill's kind of influence, to do this. Instead of looking at how the brain networks are performing, let's look at how the brain blood vessels are performing. So if you give a global stimulus as opposed to a neuronal induced stimulus, we can see changes in blood flow, not locally, but through the whole brain. So we're not just looking at brain performance anymore, we're looking at vascular performance. And then I ran into this guy right here, Joe Fisher. And I had a conversation with him. He was introduced to me by a student of his who was a resident that I was reading out with one day. And I spoke with the resident. I said, you know, I'm interested in doing this breath hold CVR. I'm just wondering if there's a better way to manipulate the breath hold so that we get control of the CO2 rather than holding your breath. Because as you know, when you hold your breath, not only do you become hypercapnic, but you become hypoxic. So that is like forcing the deoxyhemoglobin concentration in two different directions. So I set up a call with Joe. We had a discussion, and he said, I can build you a device that can control arterial carbon dioxide levels, and I'll have it to you within 6 weeks. Well, it was about 8 weeks later, and he had invented this rebreathing circuit. And basically what this circuit does is, as the patient is breathing 100% oxygen, there are boluses of carbon dioxide applied for each breath, and the amount of carbon dioxide that is applied will give a precise change in arterial blood gas. So we can actually control very carefully both, and it turns out both arterial blood gases in terms of carbon dioxide and in terms of oxygenation. And another area of research I'm involved with manipulates oxygen. And we've created, believe it or not, we've created hypoxic boluses for replacing gadolinium for measuring perfusion metrics in the brain. But that's a whole other topic I'm not going to discuss any further. And that's Joe. That's me. This is the first ResPRAC device. This is the second generation of the device. And now we're up to almost the 5th generation, which hopefully is going to be FDA approved. So the primary value of this device is that we can precisely control arterial blood gases. And in fact, it is as accurate in obtaining an arterial blood gas as an arterial blood gas measurement is in and of itself. And we've made those correlations with arterial blood gas sampling. And what we feel we can do with this device is not just measure the magnitude of the speed of response to a carbon dioxide vasodilatory stimulus, but the device is so fast we can change CO2 by 10 millimeters of mercury in one breath. So we can measure the speed of response of the vessels. And I think these are new biomarkers of vascular performance. And we published our first paper in 2001 using the device. So my disclosure is that because I was a co-inventor of the device, I figured out an application for it. I was allotted shares by Thornhill Research, and I said, wow, that's great. I didn't expect that. So it turns out I actually hold a minor equity position and just recently received the first dividend from Thornhill for that purpose. So that's my disclosure. Basically, the ResPRAC device is being sold to major universities for research purposes. And Thornhill is not making their money on this device. It is basically an at cost that's sold to institutions. And so just to clarify where my position is with that. And then finally, I have previous and current support from a number of sources. And this is the team. So this is a list of the current people in the team. I just wanted to acknowledge them because I always forget to do that before the end. And I want to do it up front. And obviously in 20 years, this list, I could fill the whole slide, but these are just the current members in the lab. So getting to the heart of the issue. Well, the heart's important, but so is the brain. And I love this slide, this PET image, which shows glucose uptake in the human body and how little there is in the muscle. There's a little bit more in the liver. There's a little bit more in the heart, and there's a lot in the brain. So the brain, even though it's only 2% of the body weight, interestingly enough, receives 15 to 20% of the cardiac output. So that's a lot. And if you look at the amount of energy being consumed and produced, the adult human produces about 116 watts, and the human brain is 23 watts. So if you put a light bulb in a human skull, you'll feel holding the skull that skull is getting hot. So one of the reasons that there's so much blood going to the brain is not just to supply metabolites, but also to get rid of this heat. And there are experiments, I think, that can be done in those people that are doing focused ultrasound and using that kind of an application, which has sensitivity to measuring temperature changes in the brain. And there's work that could be done in that area to look at how the brain senses potentially heat. Okay, so there's a challenge. So how do we know when the blood supply to an organ is adequate in patients with vascular disease? And there are different approaches used by different services. So what do I mean by that? If we look at the heart and the brain, both have a high energy demand, and we have a coronary circulation and a cerebral circulation. And both systems need to be evaluated for the presence of the effects of steno-occlusive disease. So cardiologists have developed a cardiac stress test, but we don't have a brain stress test. That's not generally used in a day-to-day clinical setting. And I think one of the main reasons for that is when the heart's not getting enough blood, it feels pain. But when the brain doesn't get enough blood, there is no pain associated with that. There may be transient symptoms, but it's not painful. And I suspect that the rush to develop a brain stress test has not been that urgent for that simple reason. Okay, so fueling the brain, I did it sort of off the back of the envelope calculation. And glucose, we know, is the primary energy source in the brain. And the average human needs, it turns out, 40 grams an hour, which is between 2 and 3 kilograms of glucose in 24 hours to operate. And of course, the glucose is burned using 6 molecules of oxygen to create CO2. And the other interesting component about glucose is that it can be a source of precursors for neurotransmitter synthesis. But the most important thing to remember is that there are very poor energy stores in the brain. We don't have glycogen in the brain, for example. And so the brain needs a constant supply of blood. And when you're growing and you need a lot of energy to support brain, you can understand why kids just absolutely crave glucose and sugar. Okay, so the problem is to be able to supply this source of metabolites with a continuous flow while minimizing the cardiac load. And also, because we don't want to stress the heart in supplying the brain with all of that blood flow. But the important thing to remember is too much blood flow is bad for the brain, as is too little blood flow. And both of these conditions can generate free radicals, which can injure the tissue. And I'll maybe talk a little bit more about that when it comes to a concussion at the end of this presentation. So the solution the brain has evolved is to conserve energy by optimizing blood flow control locally. And importantly, this whole system was first discovered by Ramon Cajal back in 1906 when he won the Nobel Prize in medicine for physiology of the understanding of microstructure in the brain. And basically what he observed in this beautiful drawing of his was that the glial cells are sending processes and enveloping neurons, and some of these processes also envelop blood vessels. So it makes sense that these are kind of an intermediary between neurons and blood vessels as it connects the two important structures together. So what does that mean? Well, this is the neurogliovascular unit that he discovered. So we have the blood vessels, we have neurons, and we have these green glial cells. So what are the functions of the NGVU? Well, if the first function is autoregulation, and this doesn't require any any innervation whatsoever, nor does it require glial cells. It is a stretch reflex. So if the pressure inside a vessel suddenly increases, the smooth muscle in the wall of the vessel contracts. We can see that the set point of that can be modulated by these dark lines, which represent the autonomic nervous system, which do regulate the resting tone of the peel and surface vessels in the brain. Then there's neurovascular coupling. When a neuron becomes active, it sends signals for increasing blood flow. That's how fMRI works. And then we have gliovascular coupling. And again, we see the glial cells connecting with neurons and blood vessels. And this is really elegantly pointed out in this Atwell paper from Nature in 2010, where we see the synapse, glutamate is released, and glutamate goes to both astrocytes with receptors and to neurons with receptors. Now, neurons, of course, activate, and when they activate, they release nitric oxide, and we have neurovascular coupling. So this is the smooth muscle in the wall of the vessel dilating in response to nitric oxide. If we look at the glial cells, they can respond in different ways when neurons become active. If there is an insufficient blood supply, they can send these two metabolites to dilate the smooth muscle. Or in other circumstances, they can send arachidonic acid and they can actually cause vasoconstriction. So importantly here, neurons can only do one thing, they dilate vessels. And astrocytes can do either dilatation or constriction of the vessels, depending on the environment they're experiencing. And glial cells are constantly kind of housekeepers. They're sensing neurotransmitters, potassium, pH, oxygen concentration, et cetera, et cetera. So the glial cells are very important in control of blood flow in the brain. Okay, so and then there's signaling redundancy. Many labs have tried to block a lot of these pathways, but the bottom line is you can never completely block the NGVU. And it underscores therefore, how important the NGVU is in terms of its own built-in redundancy for controlling cerebral blood flow carefully. Now, the final effector mechanism in this whole pathway I've been alluding to is a smooth muscle tone. So what is the tone in the smooth muscles? As the tone increases, they constrict, the lumen gets smaller, resistance increases, flow drops. So he or she who controls the smooth muscle cell controls brain blood flow. So we can take control of this smooth muscle by giving carbon dioxide, which has a direct effect on that smooth muscle tone. And it's likely mediated through either potassium or pH, and we're still not 100% sure about how that works. Now, there are diseases that do affect the NGVU, and they're glial, neuronal, and vessel wall in nature. And importantly, there are two versions. There's extrinsic and intrinsic. And by extrinsic, I mean that the vessels in the brain can be entirely healthy, but there could be a stenosis in the carotid artery in the neck, for example. So that stenosis increases resistance, drops the blood pressure, and the NGVU reacts to it. So it causes vasodilatation, but that causes a limitation in the degree to which the NGVU can respond to neuronal stimuli or other vasodilatory stimuli. Then there's the intrinsic diseases. So these are patients without large vessel steno-occlusive disease. And there are a whole array of different forms of diseases that do that. So for example, neuronal may be a direct attack based on immune responses from lupus or from limbic encephalitis, for example. A glial condition may be, I'm going to talk about this later, possibly concussion, because we often think that neurons are disrupted when there's brain injury, but no one talks about the effect of the connections that glial cells are making to vessels and to neurons themselves, as I showed in Cahal's slide. Why not glial cells also being injured in concussion, disrupting their fine regulation of blood flow control? And so I can go through a number of these, but the beauty of doing cerebrovascular reactivity mapping is you're not just looking at steno-occlusive disease, you can study a whole array of different cerebral disorders and can detect disorders, the effect of those disorders on brain blood flow regulation. And I'll talk about that as well. But we're still in the dark ages a bit. So we have structural metrics for looking at cerebrovascular disease, and we have some functional ones, which are based on resting state. So we have multi-phase CTA, we have this Tmax index, we have hypoperfusion index ratios based on these perfusion studies, but we don't have CVR. So what I'm going to do is I'm going to make an argument for CBR as we go along. And it's interesting because we're hearing things from cardiologists about this, which I thought was kind of humorous. So this is a paper that was recently published in 2021. And here are the cardiologists saying hemodynamically significant lesions are associated with a particularly high risk of stroke recurrence. Well, we know that. But they're also saying that their tool, which is CFD, can benefit understanding the cardiac physiology and the coronary circulation. Why not apply the similar types of functional testing to the brain? And CFD simply measures the pressures before and after a stenosis, and they can calculate blood flow based on that. So they're suggesting we should step up to the plate and do something more. So moving away from resting blood flow metrics, reactivity is defined here as change in blood flow per change in stimulus. And it's all based on smooth muscle tone and flow resistance, which is under constant modulation. It's always changing. The brain activity is always changing, and the smooth muscle tone is always changing. But we can measure the set point of that smooth muscle tone, and then we can see how much and how quickly this smooth muscle tone can respond to a global vasodilatory stimulus. And we can do it quantitatively if we're good with the stimulus and the blood flow measurements. So the primary flow mediators that we're seeing have different speeds. There's fast responses, which is blood pressure. This is like a knee reflex. It happens almost instantly. Then there's the kind of fast responses, which are to CO2 and to tissue signaling, including neurons. And then there's the slow response to oxygen. It takes about 60 to 90 seconds before we start seeing any kind of changes in smooth muscle tone following manipulation of oxygen. So the whole goal here is to precisely control CO2 levels during isoxia, and we want to have a quantitative stimulus to do that. But we also need to measure blood flow. So here are our tools. We have different types of imaging modalities. We have different methods for changing the stimulus. And what we've chosen basically is to use MRI and carbon dioxide for that purpose. The good thing is we have solved this half of this equation, which is quantitation of the carbon dioxide stimulus. But we don't have a perfect way to measure blood flow. And right now I'm going to make an argument for bold MRI over anything else. So mapping the dynamic changes. What do we want for an ideal mapping tool? Well, we want something that's fast, an MRI pulse sequence that measures CBF accurately and quantitatively in the setting of advanced steno-occlusive disease. And this is important. I can tell you in advance that ASL works beautifully when the blood vessels are healthy, but once you get to advanced steno-occlusive disease, it starts to break down. We also need to have the sequence to have whole brain coverage every 2 seconds or so. We hope that the flow is linear. The signal response is linear with regard to the flow. We'd like to have spatial resolution on the order of the cerebral cortex, which we now have, as I showed you when we started the presentation. And we also need to be immune to susceptibility artifacts near the skull base, and we don't want to use contrast agents. So P-Castle versus Bold. Well, the beauty of ASL is that it truly measures CBF. The problem is that it's noisier. It has poor sensitivity to slow flows because of T1 relaxation effects, or due to spin hang up in proximal vessels from lengthy collaterals, I should say. There's a labeling efficiency variability. So if you have an occluded carotid in the neck, what do you label? How do you know the external carotid is being efficiently labeled? And then insufficient temporal resolution. We're talking about minutes rather than seconds, although there are some implementations of ASL that may solve that problem in the future. Problem with Bold is it's not linear, but it is near linear in the range of CO2. I'll show you that. CO2 stimuli we apply, and then it has very high temporal resolution, which is great. We get whole brain coverage, which is great. Again, it's a surrogate of CBF, so that's not so great. However, if you look at 3 groups of individuals, all with different resting PCO2s, which we encounter in the population, and you look at the Bold signal response in relation to the CO2 that we apply, if we look at the most common group, the green group, this is where your resting PCO2 is between 35 and 40, and we see a fairly linear response. It's not perfect within the range of CO2 stimuli we apply, and the same is for the other 2 populations as well. So it's, I believe, a reasonable surrogate. Now, there are a couple of implementations of ASL. This is the one we have. This is the one I would like to have. So with current PCASL, we label in the neck and we wait for the spins to get to the brain. And like I said, if there is long collateral pathways, or there are long collateral pathways, then we're going to be sensitive to delay, and we may lose the signal, or it may hang up in major vessels. It also doesn't have the temporal resolution. And when I say where is the label, that's exactly what I mean. Where is it at the time of sampling? Has it made it to the microcirculation or not? The tag made it to the microcirculation. And then FAIR is perfect. It labels literally in the same slice that you're acquiring the signal from. So it's less sensitive to delays in the circulation. It has, however, limited brain coverage, only a few slices. There may be a P-core implementation with Siemens where we can do multi-band slices and get maybe down to a 2-second temporal resolution. So the two metrics we're going to measure, magnitude and speed of response. We have the quantitative vasodilatory stimulus, and this is what our current stimulus pattern is. It takes about 12.5 minutes to apply, 2 minutes of resting bold, then we step up to 10 millimeters mercury of CO2 over resting values, another resting interval, and then we drop the CO2, we hyperventilate the patient, and then we slowly increase the CO2 up this ramp. So this allows us to measure the speed of the response, because I'll show you there's actually an exponential rise in the bold signal after this one breath step and increase in CO2. And then with the slow ramp, we allow the stimulus to arrive in the microcirculation. So we're not sensitive to these delay effects. So we get the true magnitude of the response. And this is what our end tidal stimulus looks like coming off the device. It's very, very precise and accurate, providing that the patient is cooperative. So this is a cooperative patient. And sometimes we get a bumpy signal if the patient is a little bit less cooperative. And here's a sample of a patient that, if we look at gray matter, which is this magenta line, we can see that it matches the end tidal very closely, but we do see this sort of slower rise in the signal in response to that stimulus. And then we can see with the whole brain sample, this mixes gray and white matter. So the white matter has a different and slower response, so it doesn't have quite the same quick rise as you see with just the gray matter. And what we always do is we measure the blood pressure during these scans. So we sample it, as you can see here, about 7 or 8 times, and we measure the mean arterial. And if the mean arterial exceeds 10 millimeters, and this is just at the threshold, we start to worry that the CVR map could be falsely better than it should be based on elevation of blood pressure. So we measure the magnitude of the response as the percent change in the MRI signal per millimeter of mercury. It's very simple. It's just a linear correlation. And the way we measure the speed of response is we take this exponential rise in the bold signal and we convolve it against a whole bunch of different exponentials with different exponents, this tau exponent right here. And that tau exponent that fits this curve the best is simply the speed of response. We call that tau. This is the magnitude map. So you can see the gray matter has, in a normal, higher CVR than the white matter. It's usually by a factor of 2. And if we look at the speed, we see that the white matter is slower than the gray matter. So this is a little bit less. It's about 1.7 times slower than the healthy gray matter. And we've done accuracy. So we put the patient in, scan them, take them out, put them back in. We look at reproducibility. And our coefficient of variation for gray matter, this was like 20 years ago, was about 8% for gray and about 10% in the white matter. I'm sure these numbers have come down since we had even better control of the arterial blood gases with the later generations of the device that we use. So we have a reproducible stimulus. So I just want to show some of the pitfalls of ASL compared to bold. So we have flare. We don't see any IV sign in this patient, but we do see severe bilateral carotid stenosis or occlusion in this patient. No MCA is visible, at least M1s. So we do the ASL, and even though this looks like relatively symmetric disease, we see a very asymmetric ASL pattern. So which is the healthy side and which is the unhealthy side? Is this normal blood flow? As it should be around 50. This can't possibly be normal blood flow because this is in the high 80s. So that's physiologically impossible. But I think this is probably a sign of collateral blood flow, that there are collaterals and there's buildup of the tag prior to getting into the microcirculation. And we can't distinguish cortex from vessels on the surface of the cortex because we don't have the real enough spatial resolution to do it. But the truth is told in the CVR. So here we have a reduction, but it's still positive reactivity. We have no steel physiology in this patient. So we would say the right hemispheric collaterals are relatively effective, and the left hemispheric collaterals are very effective. Here's the patient I started the presentation off with, and I thought this would be interesting because now we've implemented a new version of PCAS. So this is the 3D multi-delay. Here's that patient I showed you earlier with steel physiology. We saw the ASL map and we said, this can't be true either because this is the healthy hemisphere. This has normal blood flow, and this hemisphere has virtually no blood flow. It's extremely slow, or low, I should say. And I think this is because the collateral pathways are still long and we can't capture the signal, even though our delay in the the longest delay in this acquisition was 4 seconds. At this time, at 4 seconds, you're going to lose a lot of the spin tag based on T1 relaxation effects. Nevertheless, the ASL does point out that there's an abnormality here, but if you even look more closely, we see that the CVR is not so bad as we get to the top of the brain, whereas this ASL almost has no signal there. So there's something still a problem with the long collateral pathways, even using multi-delayed PCASL. So we think that ASL assesses the presence of collaterals, but CVR assesses their efficacy. Then the FAIR implementation I mentioned before, where we're labeling and imaging in the same slice. We did that correlation with CVR and we published that paper, and there's very good correlation between FAIR ASL and bold ASL. And I would love to replace bold for this purpose with FAIR, but the problem, like I said, it is not covering the whole brain for us. And a former student of ours, Jorn Fierster at Zurich, is now doing a lot of CVR work, and he has access to a PET scanner. And they looked at bold, CVR, and PET using acetazolamide and getting very good correlation in steel physiology in their patients with advanced steno-occlusive disease. So now I'm going to show a couple of patients with TIAs, and this is where I'm finding the most clinical impact. We're doing a lot of patients with TIAs who have complex vascular diseases, and the neurologists and neurosurgeons are almost overwhelmingly. I can't scan enough of these cases, guys. I don't have the time in our really overbooked MR schedule to scan all the patients we probably need to be scanning. And here's an example. Here's a tight carotid stenosis. We have normal CVR. We say these are very effective collaterals. These are patients with having TIAs. Here's another TIA case, tight carotid, steel physiology. Simple. This patient doesn't need an urgent surgical or endovascular intervention. This patient, the only way you can treat this patient with all the medicine you want, they need to have this fixed. This is a procedure that needs to be done. So that's where it's useful. Here's a nice example of a man with hypertension, vascular risk factors, was having TIAs, had small stroke, had a carotid occlusion. The occlusion was relatively recent. We see this track sign. We did CTP. There's an area of prolonged MTT. We have a small area of ischemic injury. They wanted to take the patient for an ECIC bypass. We had stroke rounds, and I said, you know, let's do a CVR study. We did it urgently. So this was after the patient had already been admitted and was on heparin, was still having the TIAs. We did the CVR and we showed, yeah, it's a bit reduced, but it's not really hemodynamic. This patient has effective collaterals. You need to optimize the medical management. That was done. The symptoms, however, persisted for 10 days, and I was kind of getting a bit worried about this. But at the 7-week follow-up, there was no further ischemic injury, and the patient did quite well. So we avoided an unindicated neurosurgical procedure in this patient. So now, how do we formalize the brain stress test? We have something that seems to work in individuals. Can we make it work and be quantitative enough so that we can measure the degree to which these vascular performance metrics are impaired? And the idea is to really apply them to really understand the physiology in single subjects. And what we've done to this point is we've developed the CVR. We have a quantitative stimulus. It's reproducible. We have the precise manner in which to stimulate the vasculature, what we next need to do is develop atlases. The first one is a normative CVR atlas. So we measure the speed and magnitude of the response in a population of healthy individuals, merge that data together. So we get the mean and standard deviation on a voxel per voxel basis of healthy brain. Then what we do is we can do individual Z-scoring in those patients. So we can take our patient and compare it against the atlas and see how much they deviate, their CVR deviates. Then we develop an interval difference atlas, and that atlas is done by comparing healthy controls at 2 different points in time and looking at the difference in their CVR values, which are then based more on variation in day-to-day physiology and MRI instrument variations. And then we can do Z-scoring of interval differences in single patients. So if they have follow-up studies or multiple studies, we can accurately gauge the differences in their CVR. So here's our atlas of healthy controls. And so then we develop our atlas, our interval different atlas. Like I mentioned, fluctuations in physiology and MRI electronics will be controlled by this atlas. So we take controlled on day 1, control on day 2, subtract them, get an interval difference map, do that for a whole bunch of controls, merge their interval differences, and we have an interval difference control atlas. We can then compare voxel-wise against a patient, against that patient's interval differences, and this is how it works. So we have 2 CVRs done 10 months apart. Is the patient getting better or are they getting worse? So here's the interval difference map. We compare it against the interval difference atlas, and we see parts of the brain are getting better. This patient was treated and has improvement in the steel physiology in that hemisphere. So here's another example. Here's a patient with ECIC bypass, had a left MCA occlusion. The CVR showed steel. So of course, when we compare that patient with our Z control atlas and look at the Z scores, we see that even the right hemisphere in this healthy patient is reduced by somewhere between 1 and 2 standard deviations below normal. That's the healthy hemisphere. So now we know that is also affected. And what can happen is sometimes the healthy hemisphere is actually supplying blood to the unhealthy hemisphere, and it consumes some of its vascular reserve to do that. And of course, we're more than 3 standard deviations or 2 standard deviations below normal in most of that left hemisphere, and that includes the areas of steel physiology. So we have 3 different studies. Let's compare 2012 with 2016. And here's our interval difference map. So we can see, despite the fact that there's still steel physiology, we can quantitate the degree to which that ECIC bypass improved the left hemisphere vascular reactivity. Talk a little bit about safety. We published in Radiology after about doing 400 to 500 cases. And then we had another abstract presentation at the RSNA on about 1,050 cases. And basically what we found is that, and now we're up to 1,300 cases, we have had no severe outcomes in any of these patients. We had 1 patient who became unresponsive for a brief time in the scanner. We didn't know whether they had a TIA. At that time, we didn't know whether the patient had a stroke. We didn't know if the patient had a seizure. So the patient was taken out of the magnet, brought to the emergency room, was evaluated, by then was fine. And we never really determined what happened in that patient. So that was, I guess, the one major event that we've had in 1,300 studies. We have claustrophobia at 3%, but that's probably what it is in the healthy population anyway. And then about 5% was discomfort that wasn't specified. So overall, we have roughly, I'd say about a 92% success rate without having severe, well, we don't really have severe reactions, but without having some of these reactions that may limit the quality of the scan. So I want to talk briefly about chronic neurovascular uncoupling. So now we're moving away from TIAs, but to a new type of neurology where the brain's not getting enough blood flow, but they're not having acute ischemic injury. And C. Miller Fisher, the father of stroke, he was the first to describe TIAs and first to understand that emboli from carotid atherosclerosis could cause stroke. And he was the first to associate bilateral carotid occlusions with progressive dementia without ictal events. So what's happening in those people? Well, if we look at collateral blood flow, here's a patient with a stenosis. or actually a healthy person, we have full opening of the vessels to a vasodilatory stimulus. Here's a patient with a stenosis. They consume some of their vascular reserve to counteract this high resistance, to keep the resting blood flow normal. So the problem is they can't fully respond to further vasodilatory stimuli. And that's the key. So now if someone has poor collaterals, they use up all of their vasodilatory reserve, and they have very limited to respond to any kind of neurovascular, vasodilatory, or neuronal dilatory stimulus. So when neurons become active in patients like this, what happens? So here's a patient with carotid occlusion I've shown before. They have good collaterals. So the question is, what if they had poor collaterals, and then what are the long-term consequences of this physiology without acute ischemic events? So with acute ischemia, we know that severe limitations in blood flow damage the brain within minutes. But this chronic ischemia, what is it doing to the brain? And does the tissue actually deteriorate in terms of this lack of an increase in functional hyperemia in months or years? So what we did was we had patients with unilateral steno-occlusive disease, and we looked at where the steel physiology was, and we mapped the cortical thickness, and we compared it to the cortical thickness on the healthy side of the brain. And what we found was that the cortex is 8% thinner on the steel side. Not only that, but ADC was elevated in the white matter of the abnormal hemisphere compared to the healthy hemisphere. Colin Durdine actually did this with oxygen extraction fraction in PET and found that as oxygen extraction fraction increased, the cortical thickness decreased. So there was a validation with PET. And then finally, what's interesting, Jorn Fierster, again in Zurich, our prior fellow, he looked at this and he said, what about revascularization? Can thinning be reversed? And in fact, he found that. He found that the cortical thickness increased. It might have lost 8% and increased back to 5% after the cortical thinning. So it's not completely irreversible. So even though we found cortical thinning, we found decreased fractional anisotropy in white matter, we had decreased NAA in the gray matter, and there was progressive loss in function, neurocognitive function, the people were not having irreversible injury. So I think what's happening is the neurons aren't dying. They're just losing the dendritic arborization and the synaptic density. The complexity of the networks is being lost. And I think anyone who deals with patients like this knows that cognitively, they're not quite as sharp as they used to be, even though they're not having strokes. And this is what I think C. Miller Fisher first found. We also know that hemodynamics are a risk for stroke up to 6 times. So there's a double hit with hemodynamic impairment. There's decreased neurological function, increased risk of stroke. And in a recent meta-analysis, there was poor statistical correlation between stroke risk and a degree of stenosis. So we got to start moving away from NACIT. So how do we show the impact of stenosis? How do we assess it? Well, I think that can be difficult without having accurate measurements of vascular reactivity. And I just want to underscore this by this graph, which looks at percent stenosis versus gray matter CVR. And this is our Z-score mapping. And a normal Z-score means that you have normal brain. If you have a lower Z-score, it means your cerebral vascular reactivity is dropping. But look at the range of stenoses. There's a high proportion of CVRs that are within this normal range if you consider plus or minus 1 standard deviation normal. In fact, 32% of total occlusions have normal CVRs based on this. But there's a large percentage of them that have abnormal CVR. So how do you know if somebody with 90 to 100% stenosis has effective CVR or good collaterals? So there were some interesting studies. We have the Sampras study, the COST study. These were in hemodynamically unselected and selected patients, but they found that medical and surgical outcomes were the same in terms of risk of subsequent ischemic injury. The JET studies were interesting because the JET 1 was the first study that showed revascularization actually lowers the risk of stroke, although there are issues with this, how the study was conducted, but it was statistically significant at that time. And then the JET 2 study was done looking for a threshold of stroke risk, and they found that a CVR reduced close to 0 or 90% lower than normal was the key. So it wasn't steel, it didn't have to have steel, you could have CVR 90% lower than normal, and they were in the higher risk group for having stroke. So I'm going to kind of breeze through this assessment of collaterals quickly because we're running out of time, but Right now, we're using resting metrics, CBF, CBV, MTT, Tmax. They're based on these different stages of ischemia, where these resting metrics change drastically in stage 2, where patients are on the verge of having a TIA or stroke. And we measure these things using convolution techniques with perfusion imaging, and we look at the residue function, and the residue function tells us the time between the peak of the residue function and the 0 point is Tmax, and the longer the Tmax, the more risk of injury, the poorer the collaterals would be, is what is being currently investigated. And then the area under the curve is the cerebral blood volume, and the time to peak is the CBF. So how does Tmax predict infarct growth? And these are patients in 2 studies, the VISION and the CATCH studies, where they examined TIAs and minor strokes. And what they found was that the ROC analysis for Tmax with a threshold of 4. Now, this was a threshold that was determined by prior studies investigating acute stroke, we're all familiar with. They found ROC values that were kind of okay. 0.81 is pretty good, but an ROC of 0.66 in the other study at 90 days is not so great. So that means there must be some mud in the water here. What about DSA? Is it the gold standard for assessing collateral blood flow? This Hassan study is fascinating because there is an ASITN SIR scale for assessing collaterals on DSA, and that's been used in randomized controlled studies. How good is it? And they measure the visible change in filling over time. So they look at how slow collaterals fill or how rapidly they fill. So it's all about the speed at which collateral blood vessels or existing blood vessels fill on DSA. And so they sent DSA loops of 30 pre-treatment cases in patients with acute occlusion of vessels to 19 readers to determine how well this the reproducibility of this gold standard was. And the conclusion was concordance rates were poor among trained and experienced readers and not improved by pretest training or dichotomized grading. So the study shows important limitations for leptomeningeal collateral flow assessment within the definition of the ASITN SIR scale. That's like, that's dynamite. This is not a good scale, it apparently turns out. So that's the first red flag. What about our other metrics? Well, multi-phase CTA, we're all using this with, I think, stroke workups these days, doing 8-second delays and looking at how the vessels fills just like DSA. And we have a grading score. How well does that grading score? Looking at basically the delay in filling of these collaterals and the delay in washout of those collaterals. Well, we can create, so I'm gonna hold on to that, hold that thought for a second, and then we'll compare that with the hypoperfusion index ratio, which is defined as Tmax greater than 10 seconds divided by Tmax greater than 6 seconds. So how well do these predict outcome? This is a ratio of delays, notice. Everything seems to be delay, delay, delay. So we compare CT perfusion, which is the HIR, hypoperfusion index ratio, Tmax to Tmax, and then the multi-phase CTA, this is like DSA, and look at how much scatter there is in this correlation. It's not that good. So that's the second red flag. What about looking at the DSA directly against the HIR scale? Well, look at these cutoff thresholds. These cutoff thresholds of ROCs with not ROCs, but these cutoff thresholds are different based on whether you're comparing HIR against DSA or HIR against CTA. Now, DSA and CTA are supposed to be the same, but there's a very big difference in the cutoff for the sensitivity of the ROC analysis. So that's the third red flag. So now we're using these tools for selection of thrombectomy, and this paper comes out recently that said 13% of CT maps generated by automated software are unreliable, warranting a search for more reliable methods for making this assessment. So we have DSA, CTP, multi-phase CTA. This is thought to be the gold standard, which now seems to be on shaky ground. There's a fair correlation with CTP and HIR. And then this correlation is not so great. So what does that mean for this correlation with with multi-phase CTA and DSA? I haven't seen a correlation paper done on that, but I suspect This still should be good, but yet the gold standard is not great. So it's like, you scratch your head, what's going on with this? It's kind of like the dog chasing his tail. And I think the bottom line is we have to cut this romance with delay. All of those methods that I just mentioned are based on one metric called delay. And everything is in one basket. So all of our stuff with resting blood flow analysis of collaterals is all based on resting flow and delay, and that's it. And I think delay, I think I'm missing a slide. What happened to, yeah. So delay is at best an indirect measure of the ability of the vessels to dilate. Indirect. The hypothesis that needs to be tested is that effective collaterals are vessels that can dilate even in the presence of delayed filling. And this is where a comparison between the resting methods and CVR methods, I think, would be useful. And even Colin Durdine says, there's a great opportunity and clinical need to prove the therapeutic efficacy of hemodynamic assessment in patients with atherosclerotic, asymptomatic, extracranial carotid stenosis, and symptomatic internal carotid artery occlusion and intracranial stenosis. And that recently came out. So I'll talk about other applications. I think we're running out of time a little bit here, so I'll try to breeze through this fairly quickly. I think this is fascinating. One of my PhD students showed that normal appearing white matter that progressed to white matter hyperintensities had 25% or roughly 25% lower CVR compared to the contralateral homologous normal white matter that did not progress. So he found lesions in white matter that progressed based on the deficiency in CVR, which I think is kind of a link between why we get these things in the first place. It's kind of like chronic neurovascular uncoupling. The question is, are these things permanent? We know that there seems to be reversibility in the cortex. What about white matter? This is a patient with bilateral moya. Here are the lesions in August of 2019. Patient had an ECIC bypass. Here's a surgery. Here's a surgical injury right here. Here's the disease progression on the healthy side. Look what happened to this stenosis, this white matter hyperintensity. It healed. And if you look at the CVR, that's exactly where they had improvement. So it may be this is just ischemic demyelination that can remyelinate, just like inflammatory demyelination can remyelinate. But we don't have, I think if you want to win a Nobel Prize in medicine, and I've quoted some Nobel Prize winners, if you can figure out how to reverse this stuff, you'll get it. So now we move on. Can the brain stress test more accurately identify pre-symptomatic patients for improved stroke and dementia prevention? And I think this is probably could be the biggest application of the brain stress test. So currently what happens is, say you're middle age, you have vascular risk factors, you see your family physician, and they can apply this Framingham stroke risk profile. And I put myself through this. You can put on all these metrics, your cholesterol, your blood pressure, et cetera, your age. And based on my age, I have about, I think, a 10% risk of having a stroke in the next 10 years, and I don't have any vascular risk factors. So this is like a population-based risk profile. What if you had your own personal risk profile? So I think the hypothesis is that if we had a brain stress test with our Z-score mapping, we could develop actual patient-specific risk profiles that would be better than those Framingham stroke risk profiles. And so just before COVID hit, I had this study ready to go, and it completely fell apart because we couldn't recruit patients. But the bottom line is, I think this would be a great manner of assessing anybody with vascular risk factors who is healthy and potentially could go on to developing these white matter hyperintensities, which we know are the precursor of vascular dementia. Now, I'm briefly going to mention Alzheimer's dementia. I think Alzheimer's disease is a system integration situation where you can't just look at a gene. You just can't look at something such as impairment in blood flow. I think all the system needs to be looked at as a whole. And I think that if you begin to look at how the vascular system might play a role early on in this disease, it starts to make sense. So I'm just going to go into this quickly. I want to show this video. So you can see the glymphatics, which we think are important for amyloid elimination, which is constantly being made in the brain, could be an important pathway for getting rid of brain amyloid. And it's the pulsatility driven by the vessels that bring the CSF in, wash through the interstitium, and then wash it back out. Now, there's some controversy as to whether or not this pulsatility is actually what's causing the lymphatic system to do its job. But I think the majority consensus at this point is that it is the driving force. So this is the kind of the model. So you have patients with vascular risk factors, and then genetic factors, and then lifestyle factors that may play a role in subsequent events. So you might have these vascular risk factors. If you have good genes, you're stable. We have elderly people who are 90 years old. They don't come in with any white spots in the white matter, and may have had a long smoking history. They may have had diabetes, and they have a clean brain. They just have good genes. But if you had bad vascular genes, you may not impair your lymphatics, and you may not accumulate amyloid, but you may damage your brain anyway, and you get vascular dementia. If you have bad vascular genes and bad lymphatic genes, this is a bad combination. You may get Alzheimer's dementia. And then there's a single hit theory too, where you have ApoE4. If you just have one genetic mutation, and we know that ApoE4 impacts amyloid clearance and cholesterol metabolism. So I think the story is still not out, but it may be that it is a vascular event that begins the process, both in terms of developing vascular dementia and Alzheimer's dementia. And if you look at a mouse model of Alzheimer's dementia, you can see that there's amyloid circling the vessels. And then if you look at Alzheimer's disease with CVR, which my graduate student looked at, he found that as you go from healthy to amnestic MCI to early Alzheimer's disease, you begin to get a slowing of the speed of the vasodilatory response in the parietal regions, exactly where this abstract from the RSNA 2020 showed accumulation of amyloid. It's fascinating. And we saw this effect in only 7 patients to build this little group atlas. So there may be, I think, a link between poor CVR and amyloid deposition in the brain. Very quickly on acute concussion, we studied patients, 20 controls and 20 patients. Here's a healthy control. Here's a concussed patient. You can immediately see that the blood flow response is abnormal. So these Z-scores are actually showing a higher magnitude of response. We've never seen that in any other condition. We also found that the response was faster than healthy people. And you don't even need to do it. Once the Z-score map is visible in a single subject, you can make a diagnosis. How good was this under ROC analysis? Well, we found that the magnitude had an AUC value of 0.9 and the speed had a value of 0.94. These are the best AUC curves of any test I've ever seen for diagnosis of acute concussion. And it's all about how quickly the speed of the vessels, how the vessels are affected by the disease. And could it be some sort of injury to glial cells which lose their fine control of resting tone, so that now these vessels are more susceptible to neuronal stimulation, they're more reactive. It's fascinating. We don't know the answers to these questions, but it's a source for further research. And I'm going to now talk on the last thing, which I think is really interesting, is COVID. And you can see right away from the magnitude maps in these patients that there is a decrease in magnitude compared, just looking at this. You can see there's a decrease in healthy, and you can look at the Z-score maps showing this blue, which is lower than normal CVR. And you can also see that there's a lot of green here, that the speed of the response is slowed down. So these vessels are not opening up as much to the same stimulus, and they're not opening to the same rate of speed. And here are the graphs that support that. Okay, and these are patients with brain fog that we have been studying. So in summary, I think we've achieved standardization of a CVR. Like, we're ready to go. If there was a clinical trial that needed to be run to study collaterals or steno-occlusive disease or NASID or anything like that, we're ready for it. And I think our major referral base on a day-to-day basis are these patients with TIAs and major cerebrovascular conditions. No matter where the stenoses are, how many there are, the CVR seems to be very good to be able to assess it, and it's insensitive to delay like ASL and all that sort of stuff. It really does a great job, and I think, assessing the efficacy of collateral blood flow, but we need to prove that. And there's a great opportunity to study a whole variety of other diseases. So for example, sickle cell, which we know has, with a sickling crisis, injures endothelium. And how does that endothelium respond to standardized vasodilatory stimuli? So I think clinical trials are needed. I think we need to redo Sampras and costs and NASIT versus CVR and then collateral assessment with resting CBF metrics and CVR. And I think you just need to keep an open mind to the potential options for applying a tool that I think is a biomarker of vascular performance. So with that, I think there's a rainbow in the future with this. It just needs to be put into the right hands and to explore its full potential. So thank you very much for your attention, and hopefully I didn't go too far over. I think I'm right on time. We may not have enough time for questions.
You're right on time. This is a fantastic presentation. Thank you so much. We have a comment from Dr. Sinusis. Fantastic presentation. What are the effects of changes in regional and systemic hemodynamics and driving pressures? Do you correct for these changes? What is the effect of changes in oxygen extraction? I suspect computational flow studies would be more complex in brain compared with heart. What are your thoughts related to these tissues?
Those are important questions. And I think the first question is alluding to blood pressure, right? And there's no way to control for that. So we thought we might have had a way to control for it. We thought that if we made the patient slightly hyperoxic, that this would affect the carotid body and we wouldn't get the swings in blood pressure that we normally can see in some patients with CO2 stimulating. And that turned out not to be effective. So we're still trying to come up with a solution to deal with the hemodynamic component with the heart kind of intervening by changing blood pressure and flow to the cerebral vasculature. And the second thing is, I think this field is wide open to artificial intelligence applications, computational fluid dynamics. I mean, CFD, I think, in the brain is going to be complicated. The vasculature in the brain is able to control blood flow locally, whereas I don't know, and maybe I'm wrong about this if someone wants to correct me, that the vasculature in the heart is able to control such regional components of the myocardium as the brain can control components of networks. So I think the brain is a far more complex system, and it'll be a challenge to study it.
Thank you again. And in the spirit of being on time, we will hold off any more questions. We're very grateful for your expertise and this fantastic presentation. And we're really looking forward to continue working with you as we're building our clinical advanced image processing lab and hoping to bring this fantastic method to Yale.
Thanks, Miriam, and it was a pleasure speaking with you. I'm sorry I went a bit over time, but if anyone wants to email me, I'm happy to answer their questions.
Thank you.